Hi everyone, this is Chris Ng here, and this is an adjunct video on transgender family planning. This talk has been requested by students from previous years, and hopefully you'll find this interesting. Just starting off with some disclosures, I don't have any conflicts or affiliations with industry or pharmacy, and the other big disclosure is I'm not an expert on this topic. I didn't receive any formal training during my residency, and I actually have not had the privilege to take care of any transgender pregnant patient. That being said, this is exactly what being a physician is nowadays. It's constantly updating yourself and trying your best to learn to best serve your patients. So hopefully you'll learn alongside me. So first of all, why should we care about transgender pregnancy? And the fact is that transgender individuals are estimated to be about 0.5% of our population, and these studies are largely underestimated due to a lack of comfort disclosing this information. And transgender individuals face significant barriers to care, including unsafe and non-inclusive healthcare environments, especially like a birthing unit, which is heavily gendered, as well as significant social stigma and discrimination. There's also a lack of knowledgeable healthcare providers, something we're hoping to change through your curriculum. So, do transgender people desire pregnancy? And studies will show that actually they have very similar reproductive desires to cisgendered individuals, and that transgender status does not interfere with their desire to reproduce, but does alter their perception and meaning of family and parenthood. There's also large concerns about the effect of pregnancy on their bodies, and they're worried about increasing discrimination and stigma during their pregnancies. One of the big things to talk about is fertility planning is something that we actually need to be discussing prior to initiating any medical or surgical transitioning. And this is actually really key because there's a whole wide variety of fertility techniques, a lot of which has to be done before we transition. So people can choose to get pregnant through sort of normal penile-vaginal intercourse. They can choose to pursue in vitro fertilization plus minus a surrogate if they want. And one of the bigger options that are now more available to patients is ovarian tissue cryopreservation, as well as embryo banking, which is sort of more standard IVF and freezing eggs. And this is important because, again, this has to be initiated fairly early. And again, these are barriers to patients because there are significant costs to assisted reproductive technology. And again, medical gender transitions can actually happen before people find their long-term partner or partner. And fertility treatments often require cessation of their hormone treatments while they are undergoing these IVF cycles and such. And also, it speaks to a need for contraception. The majority of transgender and non-binary individuals are actually at risk of unplanned pregnancy. Of course, this is very specific to the individual, and it's important to make sure you ask them their sexual orientation, who their sexual partners are, and whether they've undergone gender-affirming surgery or not. And in this population, unintended pregnancy is actually very common, as high as up to 30% in one study, and abortion rates actually occur at similar rates to cisgendered individuals as well. And it really speaks to the need that reliable contraception is especially critical if they're on testosterone therapy, as this has been known to lead to congenital abnormalities, especially in vaginal abnormalities in female fetuses. So one of the best studies I was able to find on family planning in transgender men was actually a survey done of 197 female to male transgender men. And they basically they recruited at major LGBT centers in the US, and they were able to find 197 respondents. And in that group, there were actually 60 pregnancies reported from 32 respondents. And over half of them reported that healthcare providers actually did not ask them about their fertility plans. More importantly, only 60% of them were using contraception, despite the majority of them being actually on testosterone therapy. And 16% of them actually reported that they were just using testosterone alone as a contraceptive. And more concerningly, over 5% actually reported that their healthcare provider actually advised them that testosterone was sufficient for contraception. Just taking a step back talking about testosterone, I hope you'll get lectures throughout your training about the use of testosterone replacement therapy. And again, it provides lots of benefits to our patients. It allows changes to their skin, their hair growth, deepening of the vocal cords and voice. It leads to changes in muscle mass as well as fat redistribution, and in general just reduces gender dysphoria. And from a gynecologic perspective, it actually provides a lot of benefits from reducing oligomenorrhea and hopefully amenorrhea as well. However, even if you are able to achieve amenorrhea with testosterone, ovulation and pregnancy are still possible. And multiple studies have confirmed that pregnancy can still occur while on testosterone therapy. So So one big takeaway is testosterone should not be recommended as a form of contraception. So what are contraceptive options? Certainly the most common form of contraception used by over half of transgender men is actually condoms. And again, that's reasonable. You just need to really caution them regarding the typical use failure rate of 18%. Long-acting reversible contraception, like IUDs and implants, are highly reliable, but this population might be slightly more hesitant due to the need for a pelvic procedure to insert the IUD. But this also provides significant benefits in reducing the frequency and amount of menstrual bleeding, as well as hopefully leading to amenorrhea as well. Finally, combined hormonal contraceptives are a decent way to provide contraceptive benefits. This is something that people are often very hesitant about as they're worried about the effect of the estrogen on their transition. And it's important to warn patients about the side effects like chest tenderness that may develop, especially in the first couple of months of treatment. Thankfully though, this does seem like it's a reasonable and safe option. There's currently no research demonstrating any negative or positive effect on exogenous testosterone routes, and lots of people have used this successfully. Finally, if accidents do happen, we do stress emergent contraception is available for them. So both the standard levonorgestrel, sort of Plan B contraception, or ulipristal acetate, both are recommended in these patients. But there is very limited data on effectiveness, especially in combination with testosterone therapy. Ultimately, a copper IUD is the most effective form of emergency contraception, but again, this is less likely to be acceptable to transgender men due to the need for a genital procedure. So let's say we are moving forward with a pregnancy. So it's important to think about some of the challenges that transgender men face while pregnant. One of the first things is how do you disclose your pregnancy status? Do you present as a cisgender woman? And this has benefits because it limits some of the discrimination they may face, but this often sets back their social transition and can increase gender dysphoria. You can present as a non-pregnant male and try to hide the pregnancy, and this decreases some of the discrimination they may experience. They will often use techniques to conceal the midsection as well as chest tissue using chest binders. But this also limits the access to social supports and resources. All the huge support system available to pregnant patients is gone now. And then another option is to present as a pregnant male. And this does allow for affirmation of their gender identity, but definitely has been associated with an increased risk of discrimination. So this is a deeply personal choice, and we support our patients regardless of how they want to proceed with their pregnancy. Other pregnancy challenges, there's definitely an increase in gender dysphoria triggered by pregnancy, and this can be due to cessation of testosterone therapy prior to conception as well as during the pregnancy, as well as the physiologic changes of pregnancy such as chest growth. One common recurrent theme in narrative studies have suggested that people feel a loss of bodily autonomy that is quite bothersome. Mental health is also a huge difficulty. There's significant social isolation after achieving pregnancy. Our typical means for assessing for mental illness in pregnancy, such as the Edinburgh Postnatal Depression Scale, is not as relevant, and the questions aren't tailored to this population. And there's also very limited resources and support groups for pregnant patients who are transgender males. In addition, there's significant fear and decisions to be made about birthing preferences. There's just general fears of childbirth, such as pain, fears of complications. And this is also compounded because you're now entering a very highly gendered birthing unit, many of which are called women's clinics. There's a significant fear of transphobic care and discrimination leading to poor care, and they're often quite hypervigilant, and they're worried that people are going to treat them improperly and potentially cause harm. And this leads to a higher incidence of home delivery and midwifery care because the typical healthcare systems are actually failing to meet the needs of these patients. One final subject to touch upon is just mode of delivery, and this is such an individual decision. Some men will choose to have cesarean sections because this limits the need for pelvic examination and allows them to dissociate from the birthing process. Others may choose to have vaginal deliveries, and this provides significant meaning to them in a sense that sort of the reproductive organs had a purpose or have a purpose for them. But again, this is a very individual decision. So what can we do about this? What can we do to provide better care? And this starts with what we're focusing on in our curriculum is really inclusive language. We want to give people the opportunity to document their own gender identities. You'll see a lot of intake forms have now been changed to allow people to declare their actual pronouns, asking about sexual orientation and chosen names. And ultimately, you're going to screw up. I screw up all the time, and it's actually really important to acknowledge these mistakes, apologize, and correct them. Almost all the transgender and non-binary patients I've met have been very kind and very understanding as I try my best and screw up often. Pelvic examination, again, it's really important to limit pelvic examination and explain what is actually essential and why we're actually recommending examination. And trying to use neutral terms like chest feeding or frontal pelvic outlet can be more reassuring to patients. And often we'll just ask them, what do you want us to call this? Provider education is really important. This is a fairly new topic, both in terms of medical education as well as in the literature. And this is going to take continuing ongoing education for all of us to do a better job. It's also really important to develop awareness of local resources. And finally, it's important to start looking at birthing unit cultural change. And this starts from everybody, but also from the top, from the OB/GYNs that are involved, or family practice OBs that are present. We have to lead by example if we're going to change this culture. And again, change will happen. It's going to be slow, but it will eventually happen. In terms of local resources, I would really highlight Transcare BC. We have an amazing network of transgender or trans care providers that are available through this website, lots of information. And I know that all the transgender men that have been referred to me for gender affirming surgery have all gone through amazing counseling and hormone therapy consultations through Transcare BC. So I would encourage you to take a look at this website if you're interested. So here's some of the references. I definitely would highlight number 3, which is an article from Dr. Bessie, Experiences with Achieving Pregnancy and Giving Birth Among Transgender Men. This was actually, I found this very compelling. So if you have the time to read it, that'd be fantastic. Questions and comments, you can always reach me through my UBC account, which I won't share here on YouTube. I'm also available through Piazza throughout the week, of course. So I hope you enjoy the rest of your week. Take care. Bye.